I would like to thank the organizers for inviting me and Dr. Begley to provide such a beautiful introduction to what I think is really exciting and growing field of liquid biopsy opportunity in neurooncology. I will try to build upon his talk and focus particularly on pediatric brain tumors and challenges in there, because that's where I think the consortium such as BLOODPAC can be extremely helpful in facilitate larger studies. So one of the major changes in neurooncology has become that we have really moved away from defining brain tumors histologically towards defining them molecularly. And the tumors that were believed to be a single histological entity before, such as shown here as a glioblastoma, medulloblastoma, or ependymoma, we now know are composed of multiple different molecular subtypes that vary in terms of their drivers, in terms of their outcomes, and in terms of the need for the management, and as I'm going to show you also, the monitoring. The way we and others have approached to deal with this problem of having histologically similar diseases, but molecularly and clinically very different, is development of comprehensive molecular platforms, one of them being a whole genome DNA methylation that subclassifies brain tumors using whole genome DNA profiling and a random forest classification into these distinct molecular subgroups, in this case using Illumina methylation epic B chip. So you can imagine that if you have two children with the same posterior fossa tumor as shown here, you can see that they both have the same histological diagnosis, medulloblastoma grade 4 by traditional diagnosis. But when you perform molecular profiling classification, you see that the child on the left classifies as a Wnt medulloblastoma, shown here, and the child on the right classifies as a group 3 medulloblastoma. And we tend to think about these molecular subgroups from the perspective of prognosis, perhaps development of clinical trials, design of clinical trials, and hopefully new therapies. But what we sometimes don't think about it is that, as Asaf nicely pointed out, is when you're bringing these children for longitudinal monitoring, is that these kids actually will also require somewhat different long-term monitoring. A child with a Wnt subtype tumor is expected to have a long survival and will probably need to be followed longitudinally for years to come. On the other hand, a child with a group 3 medulloblastoma has extremely high chances of survival, and therefore we need a highly sensitive assay with which we can monitor and capture potential recurrence early on to be able either to resume the therapy or enroll on clinical trials. So in summary, we do need an assay that can take into account molecular heterogeneity of brain tumors, and it can be sufficiently sensitive and non-invasive that it can be performed often enough to test patients, and it can be sensitive enough to diagnose them early on. Just for those of you who are not dealing with the pediatric brain tumors on a daily basis, brain tumors are rare. Pediatric brain tumors are even rarer, but we should not forget that are the most common solid tumors in children and represent 20 to 25% of all cancers in patients less than 25 years old. They're also leading cause of cancer-related death in children. While we witnessed a great improvement in survival of children with leukemia, that has not translated equally to patients with malignant brain tumors of childhood. There's been an increase in incidence in the second half of the previous century, and diagnostic delay is common with a median time frame between 6 to more than 14 weeks. Survival rates have improved, but there is still more to do, and the targeted therapy have not been as promising in brain cancers and pediatric brain cancers in particular as have been in other solid tumors. Diagnosis, management, and long-term follow-up requires serial MRIs, and what should not be forgotten is that particularly when you're dealing with small children, MRI often requires anesthesia to be able to perform MRI with a high quality. So we really need improved monitoring and for long-term follow-up of children with brain tumors. A few years ago, we've addressed the current status of liquid biopsy in pediatric brain tumors, and we focused on different samples that can be used, including urine, blood, and CSF, and different assays, including circulating tumor cells, cell-free DNA, and methylation modifications. as Dr. Bailey pointed out, I'm not going to repeat everything what he has shown, but the purpose of liquid biopsy is multifold. First of all, we can monitor pediatric brain tumors. We can hopefully find therapeutic targets at the time of recurrence, understand the resistance mechanisms, and perhaps understand also heterogeneity and evolution of the tumors during the time. There's been significant advancements in classification of brain tumors, as I've shown you, due to molecular profiling, but there hasn't really been that much of a progress in terms of biomarkers for pediatric intracranial tumors. And multiple assays have been developed, including the circulating tumor cells, cell-free DNA, DNA methylation analysis as shown in the previous talk, but also circulating tumor RNA, microRNAs, and protein subpeptide fragments. And I'm going to walk you through this table, but each of these assays have advantages and disadvantages, and it can perform a little bit of different function when we are talking about the diagnosis versus monitoring of children with brain tumors. There are significant challenges that are posed for liquid biopsy in brain tumors. First of all, compared to other systemic tumors, central nervous tumors show relatively low number of mutations, particularly in coding regions, when compared to non-CNS tumors. Despite our best effort in genomic profiling, some brain tumors still lack somatic or coding drivers, despite the fact that they have a very distinct RNA expression of DNA methylation signatures. And what is particularly challenging for development of a laboratory assay is that brain tumors are molecularly highly heterogeneous. We now recognize more than 100 distinct molecular subclasses. So while there are certain targets, such as third promoter, that are more prevalent than the others, there is incredible heterogeneity in terms of molecular drivers. And there is a presumed low cell-free DNA tumor DNA load in peripheral blood due to blood-brain barrier. And we must not forget that brain cancers are overall rare cancers. So putting together well-balanced and designed studies to be able to evaluate biomarkers is particularly challenging in brain cancers. So there's a huge need for collaborative effort to establish the value of any biomarker and validation of the assay. These challenges are even more prominent in pediatric brain cancers. Similar to other pediatric cancers, there are even fewer mutations and even fewer coding mutations, as I'll illustrate in some of our cases. There are some tumors that have no recurrent hotspot mutation or known drivers, certain subtypes of medulloblastoma or ependymoma and neurocytoma, and a large volume of blood for testing, it's often not possible. Some commercial assays require 2 10-milliliter tubes of blood, which is often not particularly practical, particularly in very small children. Pediatric brain tumors are even more rare than adult, and building a large cohort of pediatric brain cancers that are balanced for molecular subtypes is extremely challenging and requires multiple institutions because each of these brain tumors, for example, medulloblastoma, as I've shown you, contains patients that have an extremely good prognosis, such as Wnt subtype, or extremely poor prognosis as group 3 subtype. So this really requires collaborative, multi-institutional effort to obtain sufficient number of samples from the retrospective databases, but also, most importantly, to perform a prospective validation of a new laboratory assay. When I came to Asaf with ideas to profile some of the pediatric brain cancers, I have to admit that the field has not been particularly optimistic. There was a large study from the Dana-Farber group, which was beautifully designed and analyzing 564 specimens, including blood, urine, and CSF samples from 258 patients, combining an ultra-low pass whole genome for copy number analysis and a specific panel for deep sequencing of mutations and fusions. And you can see that the results were not horrible, but were not particularly encouraging. About 20% of CSF samples were positive, but less than 1.5% of plasma samples were positive, and none of the urine samples. And the detection of sequencing mutations was quite low, with 2.7% of positive plasma samples. And most of the samples, most importantly, not surprisingly, knowing the genomic landscapes of pediatric brain tumors, were insufficient for somatic mutations, with a median number of a single mutation ranging between 0 and 39 mutations. So you can imagine how difficult it is for panels to identify a signature if you're working with a median number of a single mutation. So it wasn't a very optimistic start for the blood-based cell-free DNA analysis. And most importantly, it was really positive only in high-grade tumors, so not even amenable for the lower-grade tumors. A study that came recently from Matija group at Memorial Sloan Kettering focused specifically on cerebrospinal fluid. We knew from the previous studies, illustrated also in the previous talk, that CSF seems to be a higher yield. So they analyzed 45 patients with aliquots of CSF ranging between 0.4 and 12 milliliters, which is actually quite a lot to take out of a patient. And they performed the MSK impact that contains 468 cancer-associated genes and selected introns for fusions. And they were able to detect somatic alterations in 30 out of 64 samples, which is not bad. But what is problematic is that this positive result was mostly associated with widely disseminated disease. And one may argue that if disease is as disseminated, is not disseminated to be seen on MRI, the need to undergo additional CSF collection may not be as high, and is not necessarily a good for MRD testing. That doesn't mean it's not useful. It can be very useful, as shown before, for enrollment in the clinical studies, in the clinical trials, but perhaps not the best for serial monitoring of patients. So in collaboration with C2I Genomics, we took a bit of a different approach in our pilot study, where we derived the patient-specific tumor signatures, identifying unique tumor mutations in primary tumors, perform whole genome sequencing and diagnosis, and then apply this patient-specific signature on a whole genome sequencing of the cell-free DNA tumor plasma. And we first wanted to do a proof of principle study based on all the negative studies to see whether this approach even has a merit. And what I would like to point out is why I'm particularly excited about it is they require a relatively small amount of plasma or blood we like to have at least 2, maybe 3 milliliters of blood, which is particularly advantageous for small children where large amounts of blood cannot be routinely collected. And I just want to illustrate the results of our study with a single case that highlights all the challenges that I've shown you before. And I want to first focus on the middle of this slide, where you can see the total number of single nucleotide variants, indels, and copy numbers, and these deep purple bars that showed you the number of non-coding mutations, 1,500 single nucleotide variants in the non-coding mutations, but only 16 variants in the coding mutations of the whole genome, 600 indels across the entire genome, but only 3 coding mutations. So you can see that the number of mutations in the non-coding genome is vastly higher than the number of mutations in the coding genome, which is part of the reason why targeted panels performed on cell-free DNA in pediatric cancers are really not successful. And this was a patient who was diagnosed at 6 years of age with a medulloblastoma group 4, and that's a type of medulloblastoma that is notorious that we don't actually know what is a driver, and there are very few coding mutations. The patient underwent a beautiful gross total resection, so there was no cerebral tumor left when we received the samples, but had a persistent small focus of leptomeningeal disease that you can see here in the spinal MRI, and you can see that corresponds very nicely with a positive result from the liquid biopsy test. I want to also point out is that as we've shown before, that previous studies have shown that liquid biopsy is it was positive in samples with widely disseminated disease. But here we see that even when the disease disappears on leptomeningeal on a spinal MRI, we can still detect the presence of the disease, although at decreasing level through the chemotherapy in blood, which means that you don't really need to have a huge raging disseminated disease, but that this method is extremely sensitive and can be used to detect the disease that is not present on MRI anymore. And I'm just illustrating here the copy numbers similar to Dr. Bailey's study on adult gliomas that we're able to detect very confidently in these patients. We try to see the value of this test across different clinical scenarios. You can see this is at the time of diagnosis, a high level of cell-free DNA in the blood or in the newly diagnosed medulloblastoma. That's another patient. This is a glioblastoma patient that was going through a chemotherapy, radiation, and then immunotherapy with a surgery with a drop of a ctDNA signal when the tumor was resected and treated with immunotherapy. You can see an anaplastic ependymoma patient that has been negative on imaging and followed with a test where there's a good correlation between imaging, no tumor on imaging, and no signature detected in blood. And then an example of a low-grade tumor, ganglioglioma, that has been consistently followed as a negative sample, and you can see that corresponds to the negative results from the liquid biopsy. So really, between the high-grade tumors and low-grade tumors, we can see the utility of this testing. However, the caveat is that our cohort is relatively small, and we are now currently working on expanding it, collaborating with multiple institutions to really see which of the tumors that this approach will have the highest yield. So in summary, I hope I showed you that brain cancers are rare, pediatric cancers are rare, and we really need to work together to collect sufficient cohorts to establish new biomarkers. The amount of blood could be a distinct limiting pre-analytical factor for any biomarker, a blood-based biomarker in brain cancers, and the targeted panels have showed limited success for diagnosis, and they're most useful in the disseminated and high-grade disease. CSF shows the significantly higher diagnostic yield, but it requires semi-invasive or more invasive approach with a higher risk and may not be as suitable for repeated monitoring as obtaining peripheral blood. I hope I showed you, at least from the very early studies, that ctDNA whole genome sequencing can really be utilized across the wide spectrum of pediatric brain tumors, and it can be performed in a small amount of volume of blood, which is useful for small children. And most importantly, because pediatric brain tumors are rare and incredibly molecular heterogeneous, I think it is really critical to establish collaborative multi-institutional studies to establish clinical sensitivity and clinical utility across different disease types. I'd like to thank my team at NYU Langone Health and the C2I genomics team that has been supporting, and despite all the negative literature, our efforts in this area, which we really appreciate, my collaborators from Mount Sinai and Atlanta, and of course the funding sources that help us collect the samples, without which we could not do any of these validations. And I'll be thanking again the organizers, Asaf and his team, for including us, and I'll be happy to take any questions. Thank you.